Zomato. Shreya. Shreya. Shreya Papa. Just one vada pav is sufficient, isn't it? You don't need any extra.
चल
अच्छा पुनः
Welcome, dear colleagues. My voice is clear.
Yes, clear, doctor.
Thank you. We'll start in 2 minutes time. Yes, doctor, you are ready for performing this case? Dr.
Yes,
Asim,
doctor.
I will share your case now.
Which case, doctor?
I will show now. Just hold on. Yes, doctor, this is your case.
Okay.
You have now 5 minutes to prepare and start. Yes, doctor, you can start now.
Okay, hello.
Hello.
My name is Dr. Ahmed. I will be the treating doctor for today. May I confirm you are Miss Julia, 32 years old?
Yes, doctor, I'm Julia and I'm 32 years old.
Miss Julia, we are here to discuss some issue regarding to your health and answer any concern. Is that okay with you?
Sure, doctor.
Okay, Miss Julia, can you tell me what do you know about your condition so far?
Yes, doctor, actually, I'm struggling for last few months' time with my high blood pressure. Actually, I had headache, so I went to my GP and it was the persistent headache that was coming and going. So I went to my GP, he checked the blood pressure and he found that your blood pressure is high. Then he advised me to check the blood pressure at home also. So I checked my blood pressure at different timing in my home. So I found some of the readings were also high at my home. Then also next visit, when I went to him, I showed him the uh, level of my high blood pressure. So he suggested me that you should start lifestyle modification. He advised me to do some exercises with the brisk walking, and I was a bit obese, so he told me that you have to maintain your BMI. So I did all the efforts and I managed this, and my BMI became within the normal range now. And with the low salt intake, I try to maintain my blood pressure, but I found that blood pressure is still on a higher side. And the same is the GP was thinking that your blood pressure is high. So he did some routine investigation and also the ECG. He found that all the labs are normal and also the ECG is normal, but the cholesterol was high. So together with this, I have a strong family history of hypertension and also the family history of heart attacks in my family. So I'm really bothered about this situation. So the GP has referred me to you.
Okay, Miss Julia, thank you for sharing this information with me. Miss Julia, I'm really sorry for your suffering all this period. So we will try to help you today as much as we can. So, Miss Julia, yes, you have persistent elevated in your blood pressure. In spite that you have a healthy lifestyle, as you mentioned, that you keep exercise, your weight is normal, and yes. So, Miss Julia, actually, we have many causes for persistent elevated high blood pressure in spite lifestyle and also in your age, in young age. So, one of them, it could be secondary, which means that it could be secondary to underlying disease. So it could be something hormonal problem or something having a kidney problem or sometimes with
Okay.
anxiety. So we have many possibilities for this. So
Okay.
because of that, our consultant and the treating team want to do for you a further investigation to know what the exact underlying cause of this high blood pressure. Are you with me, Miss Julia?
Yes, doctor, I'm with you. So what the consultant has decided for me,
Yes.
what is the plan he is discussing?
Okay, okay, I really appreciate that. So, Miss Julia, the plan here to do for you a further investigation. One of these investigation is investigation of your water work to a hormone that we called catecholamines. Okay, it's a type of hormones that we measured in a case we thinking about a condition that called pheochromocytoma. Do you heard about this condition before?
No, no. What is pheochromocytoma, doctor?
Yes, it's a gland problem, Miss Julia. It's a gland problem that the gland founding in upper part of your kidney. It's release these hormones which called the catecholamines, which that increase the blood pressure. So we think this is one of the causes of the persistent elevated high blood pressure in the young age people. So we need to do this investigation to rule out this condition. Beside that, we
Is
need
this
to do.
is this the only cause of high blood pressure in young patient, doctor?
No, no. There are many causes actually. This pheochromocytoma is one of them. Another
Okay.
cause that might thinking about is a kidney problem. So also we need to do for you some scan and some jelly scan for your abdomen, your
Okay.
tummy, to check for the kidney size, and even we can check for this gland that found in above your kidney. Okay. So yes, so this investigation plus other blood tests that we need to do just to confirm, to exclude these causes of high blood
Okay,
pressure.
doctor.
Mhm.
Is this the pheochromocytoma as you are telling? Is this something serious? Is it a cancerous disease?
Yes, I really appreciate your concern, Miss Julia. Actually, yes, it's a serious condition if not treated and if not controlled. And there is a possibility, actually, 10% to be a cancerous condition. But because of that, we need to exclude it because it's very serious, actually, Miss Julia. Are you following?
Yes, I'm following you, doctor. So,
Oh, okay. So after doing this blood test and scans,
yeah.
we need. Are you hello?
Yes, I'm with you.
Are you hearing me, Miss Julia?
Yes, I'm hearing you.
Hello.
Yes. Can you hear me, colleagues?
Hello, my voice
Hello.
clear? Yes.
Yeah, clear. Yeah.
What
Clear.
about my voice? My voice is also clear.
Now it's clear.
It is
Doctor.
clear.
Okay, go ahead, doctor. After doing the
Okay.
investigation, what you will do?
Okay, so Miss Julia, after doing this investigation and know the underlying cause of this high blood pressure, then we will involve a group of doctor, including the physician, including the gland doctor, dietitian, and other specialty if needed. They might
Okay.
think to start for you a medication to control your blood pressure, and then a treatment according to the underlying condition that is discovered. For example, for this pheochromocytoma, they might need to do for surgery for you. So this is, let's discuss this
Doctor.
after finish the. Okay.
Yeah, thank you, doctor.
Okay.
I'm discussing about another things. If these tests are coming normal, then what you will do?
Okay, if we find this investigation normal, we will check other causes for this high blood pressure. So one of them also, it could be related to anxiety, stress. Do you have anything like that in your life, Miss Julia?
No. Anxiety, everybody is having the anxiety, but I'm managing it very nicely. There is no stresses in my life and I'm doing the exercises. I'm really very active.
Okay, so in this case, we might think about the essential hypertension, which means that hypertension, because that you have, as you I see in your notes that you have a family history of high blood pressure. So
Yeah.
yes, we will start for you some medication to control your blood pressure, Miss Julia.
Another thing, doctor, I'm worried as my family space is strong. So is it likely that I will remain on high blood pressure medicine forever?
Yes, I'm so sorry to tell you that, yes, it's a possibility that you might need this medication for lifelong. I'm so sorry. with that, Ms. Julia.
Okay, and what about the risk of this heart attack, doctor? Is this also for me also I'm at risk to develop this?
Yes, I'm so sorry to tell you that it's a possibility, but if we control your blood pressure and the risk factor like smoking and other risk factors, we can control this, Miss Julia.
Okay. And
Okay.
how to manage my high cholesterol level, doctor?
Yes, we might need to start for you a medication. If the healthy lifestyle not decrease your lipid profile, yes, we might need to start for you a medication called statin also to control your underlying high cholesterol.
Okay.
Okay.
2
Do
minutes.
you
I will give you 2 minutes more.
okay? Okay. Do you have other concern, Miss Julia?
No, doctor, when you will do this test for me?
Yes, we will arrange it as soon as we can. Miss Julia, I will inform you about the timing. I see now that you are in a healthy lifestyle, which is good. I really encourage you to continue in this, Miss Julia.
Mhm.
And
Mhm.
also, I want to tell you at any time if you feel chest pain or vision problem or a severe headache, this all might related to the high blood pressure, Miss Julia. You need to come to the hospital as soon as you can. Okay?
Okay.
Because yeah, if not control your blood pressure, it's really a serious condition that might affect other part of your body. I'm so sorry
Okay.
to tell
Okay,
you.
doctor.
Okay.
Yeah.
Do you smoke, Miss Julia?
Yes, I do, doctor.
There's no screen appearing.
Sorry, your
Do
voice is
you
not
drink?
clear.
You smoke?
Doctor,
Yeah, I do. I do.
Oh, okay, Miss Julia, I really advise you to stop smoking because it's injurious to your health condition and even increase the risk of this high blood pressure and heart disease. Is that okay?
Okay. Okay, doctor.
Okay. Do you drink alcohol?
Yeah, I do. I take alcohol over the weekend, only 1 to 2 units.
Oh, okay. Okay. Okay, Miss Julia, what's your job?
I am working in an office, doctor, and this is an accountant job.
Okay. Do you need any kind of support?
No, doctor, I need this the further workup as soon as possible.
Oh, okay. Okay, I will arrange that and I will tell you about the exact time. Okay, Miss Julia?
Okay. Anything
Okay.
else?
Do you have any other concern?
No, doctor.
Okay, so I will give you our contact number, some brochures to read about this high blood pressure and the causes of it. And if you need any help, you can contact us. Okay.
Okay. Thank you. Okay,
Thank you.
time is done. Time is done. Okay. So when you started, Dr. Ahmed, basically you should start like what she is thinking about her condition. Okay. You have to take the idea about her condition. What do you think? Why you have the
Oh,
high
okay.
blood pressure? Yeah.
Yes, yes.
In this
Okay.
case, it is very important. And what is your expectation about our meeting today? Okay.
Okay. Okay.
And you started nicely, but if you started with this, what is your idea and what is your expectation about our meeting today? So it would be a good start, better than this. Okay, and we do not need to repeat if the patient is telling you so much detail about her condition, and like she took 1 minute and 30 seconds or more. She told you everything, each and everything. So you should appreciate, yes, I appreciate your knowledge about your conditions. So I would not like to add anything more, but I would like to know what is your idea, why you are having the high blood pressure? Okay, so, and what is your expectation from our meeting today? So from there you will start. Okay, and then you should highlight some of the causes of hypertension. Like one of the cause here is the consultant is thinking. You have to say the consultant is assessment. According to the consultant assessment, you are possibly having a disease known as pheochromocytoma. So I will explain you what is pheochromocytoma. Pheochromocytoma is a medical condition in which the gland located at the upper pole of the kidney is having benign growth. Mostly it is benign. Okay, and it is because of this growth, it is producing excessive amount of hormone known as catecholamines. Okay, as a result of this, you are having the high blood pressure. This is one of the possibility, but there are other causes also for hypertension. Please, doctor, whoever is joining, please mute yourself. Whoever is new joining, please mute yourself. Okay, Dr. Ahmed. So we have to explain about the pheochromocytoma, and then we have to proceed from there, and we have to inform that the consultant has advised that we have to do further investigation to find out the cause, and most likely in your case, most likely cause is pheochromocytoma. Is this the only cause in my case, doctor? No, there could be some other causes also, but here the consultant is thinking that you are having this this cause. So we are focusing initially on this, but at the same time we are focusing the other investigations, like we are doing the ultrasound kidney jelly scan of the kidney to find out if this any other cause
There is no
is
screen
there or not.
appear.
Sorry,
There is screen appear.
the voice is not.
There is no screen appear. There is no screen appear.
Screen is not appearing.
Dr. Shaikh from Cairo.
Her
Dr.
voice
Shaikh
is
from
breaking.
Cairo. There is no.
Okay, can you please write down your whatever you want to say? Please write down in the chat. Okay, I'm going back to the explanation, and the question will be taken at the end also, please. So whoever having the question, please write down at the chat. Okay, after this explanation, I will give you the answers. Please write down in the chat. So some of the causes of hypertension, yes, we have to say there are different causes and there are multiple causes, but in your case, the possibility of pheochromocytoma is high. That is why the consultant is targeting and advising the further investigation about this, but don't worry about that. We have to search out the other possible causes. So if it is coming normal, then what would be the possibility? Then we will review your case again. We will discuss with you after getting the results of all the investigations. We will have another meeting and we will see and sit together and we'll see what are the possibilities. If needed, we will do some further testing. If not needed, then it is most likely it is the essential hypertension. We say the primary hypertension related to your family history. Okay. So in that condition, yes. So if it is familial, so we will start the treatment, and the starting of treatment is just we have started with the lifestyle modification. Other than this, what do we have to do? We have to do some dietitian advices. Dash diet. We have to explain dash diet, that this is a specific diet, and I will refer you to the dietitian, and he will advise you for the dietary advices to control the blood pressure. So this is another important factor that we have to highlight. Other than this, she is asking about the risk of ischemic heart disease. Yes, as per family history, you are at risk to develop the ischemic heart disease. But this one also, we have to see the modifiable risk factors. So whatever the modifiable risk factors are present, we will address them and we will control them. We will try to control them. But I'm sorry to tell you that it will not exclude you from developing this ischemic heart disease 100%. But we will keep you under monitoring. You are not alone. You are not left alone. Okay. So that is how we have to answer this question. Then she told about the high cholesterol. So we have to say that again, we have to do the follow-up test for the high cholesterol. We are not going to start any medicine. Don't give the name of a statin or any other medicine that is not mentioned in the scenario. Just say that the first priority now is to find out whether you are having the pheochromocytoma or not.
It's not showing. It is not showing.
So the first priority is we have to rule out chromocytoma is there or no, because it is comparatively a serious condition and we have to diagnose this as soon as possible. Okay. Is it a serious condition? Yes, I appreciate your concern, Ms. Julia. Yes, if it is not well managed, if it is not properly treated, yes, it is a serious condition. It can be a serious condition. But don't worry about that. There is treatment available, and we will monitor you. We will keep you under treatment, and it will be a treatable condition. It will be a manageable condition. So, what treatment options are there for pheochromocytoma? So, first, we have to give the medicine to control the blood pressure, and then we have to do the laparoscopic surgery. That is the keyhole surgery. We have to say that the keyhole surgery is done, and usually, as I told you before, that it is because of the benign growth of a gland located at the upper pole of the kidney, known as the adrenal gland. So we have to do the keyhole surgery, and we have to remove that benign growth. After removal of that benign growth, your condition will become well controlled, or you may not need the like the big doses of blood pressure medicines. Okay, but at this point of time, it is early to say. Okay, so these are the possibilities. Is it a cancer? Uh, it is mostly it is benign growth, but in 10% of the cases, it is the cancerous or the nasty growth is there. Okay, so this is how we have to address the concern. So whenever the candidate is giving you a chance and the candidate is not giving you further concerns, it means time is finishing. So you have to either summarize the case, or you have to address the social history of the personal history of the patient. The smoking. So smoking is there, so you have to stop smoking because it is the contributing factor for high blood pressure also, and it is a risk factor for other diseases, not only the cancerous condition, but also the ischemic heart disease, because she is more concerned about ischemic heart disease. So inform her that you have to stop smoking, and we'll refer you to the smoke cessation clinic. Lot of support is available. Alcohol also moderation. She has to use in some scenario. The patient is telling, I'm taking a lot of alcohol. So inform this is also the contributing factor, the aggravating factor. So you have to reduce the alcohol intake also. An alcohol liaison team is available. Alcohol support team is available. We can refer you there if she is having a lot of alcohol intake. The job, the stresses in the life, in the job stresses, we have to manage also. Inform her if it is a stressful condition and difficult to cope, then we have to inform her that we may need to refer you to the talking therapy for the mood doctor. We will refer you to the mood doctor for talking therapy. That is a cognitive behavior therapy. And we have to inform her how to keep yourself relaxed, or to decrease the stress during the stressful conditions. So these are the important points that we have to highlight in this case. Any questions? So you can write down in the chat. Hormone is not a jargon. Hormone is not a jargon. Okay. Any further concerns? If you want to ask, you can ask now. Anyone can write down in the chat. Right. Okay. So disease is not jargon. Better to say it's a medical condition. Whenever you are explaining anything, you have to say the medical condition. It's a medical condition. Pheochromocytoma, it's a medical condition in which a gland located at the upper part of the kidney or the upper pole of the kidney, known as adrenal gland, having the benign growth. Like this, you have to explain in this condition, in this condition of pheochromocytoma. So any disease, if you want to explain, you can start like this. It's a medical condition in which, like this. Okay. Driving, we have to ask the patient, do you feel that your blood pressure and your condition is aggravating while you are driving? In this condition, driving is not an issue, most likely. Diagram to draw is it's just like a personal thing now, because the time is not so much. I will advise you not to do the diagram, not to make the diagram. Just explain, and that's it. That is enough. It was like before 2022, when the scenario was of 15 minutes. So that time it was okay. Now the scenario is of 8 minutes, and the 2 minutes are like 2 minutes remaining. So you have to either summarize, give the brochures and the leaflet, and address the personal or the social history of the patient. Okay, I hope it's clear. This is one of the scenario that recently came. For high cholesterol, what we have to say that continue with the lifestyle modification, dash diet, and the high cholesterol, we'll keep an eye on it, but the top priority right now is to focus on pheochromocytoma to find out the cause of high blood pressure. Okay. And if it is on the second visit also, if it is high, if it is not improving, yes, then we have to discuss with the consultant, and the multidisciplinary team will decide some treatment to lower down the cholesterol level to normal range. Clear? Okay. So any volunteer for the second case? So Dr. Pooja, actually, how we have to modify the question and answers, this is important. Okay. So high cholesterol, it just like they have given it to give you some some extra work to address, and how technically you are doing this. This is the hidden agenda, or you can say it is just like a distractor also. In every scenario, you will see some distractors are there. Okay. Anyone interested to perform in this case? This is LCC case, and the colleague who has to perform, he got stuck in the OPD and he's coming back from the hospital, so not possible for him to perform in LCC. Yes. Anyone
Sir,
who is interested?
I'm Karthik, sir. May I take this case?
Yeah, welcome, Dr. Karthik. You can take.
Thank you, sir.
Okay. So we'll give you the 5 minutes time to prepare, and we'll start this case.
So shall I start?
If you're ready, we can start. Yes.
Hello, I'm Dr.
Hello.
Karthik, one of the doctors
Yeah.
in clinic today.
Yeah.
Am I speaking with Mrs. Julia, 40 years old?
Yes, doctor. I'm Julia and I'm 40 years old.
Uh, Hello. Today we are going to discuss about your health condition.
Sure.
Yeah. So I came to know from your GP notes that you have some difficulty in breathing and you're
Yeah.
having cough and you're feeling so fatigued. So could you please
Yes.
explain more about this?
Yes, doctor. Actually, for 1 month, I'm having difficulty in breathing. It was started gradually, and initially I felt that when I'm going uphill, I am having some difficulty in breathing.
Mm-hmm.
So then I noticed that when I'm walking fast, also I'm having difficulty in breathing. This happened like in within 4 or 5 days period of time. Okay, so then I am noticing now that I cannot walk more than 100 meters nowadays.
Mm-hmm.
Yeah, and together with this, I have cough and I feel like my energy level is going down.
Mm-hmm. Mrs. Julia, are you comfortable now? Are you comfortable now to proceed
Yes,
for
yes,
further?
yeah. I'm comfortable while sitting.
Okay. Mrs. Julia, could you is there anything that is increasing your shortness of breath or relieving your shortness of breath? Any kind of that? Have
Yeah,
you
if I'm
noticed
doing the
anything?
exertion, if I'm doing the
Mhm,
exertion, if I'm walking, especially if I'm walking fast, I develop
mhm.
the shortness of breath. When I'm
Okay.
taking rest, it takes like 5 minutes, 10 minutes to catch my breath and to reach to the baseline.
Mhm. Have you ever noticed a sharpness of breath while lying flat in your bed?
No,
Have you ever wake up from the sleep after some time feeling shortness of breath?
no.
Okay. Do you have any racing, pacing of your heart?
I feel slightly heart racing while I'm having the difficulty in breathing, especially while walking fast.
Mhm. And how is the? I want to ask the patient to. Could you please tap the tap and tell whether it is regular or irregular?
It is fast and regular, fast and regular.
Regular. Okay.
Yeah.
And have you ever felt there is missing of your heartbeats, missed beats, or something like that?
No, doctor. No,
Is that occur during exertion only, or even at rest?
no, only on exertion.
Only on exertion. Okay. So could you please explain about your cough? Are you having a cough since the last 1 month, a similar duration of your shortness of breath?
Yes, yes, so for 1 month.
And are you producing any phlegm?
No, doctor, it is dry cough. Also, it is coming while I'm having shortness of breath. After the shortness of breath period, I developed the episode of cough also together with shortness of breath.
Mm-hmm. Okay. And is there anything that is increasing it or relieving it or lying to one side that is increasing it, or for example, or anything
No,
that is relieving it? Yeah.
no, no. The position is not increasing my cough or shortness of breath.
Hmm. Is it more
Lying
in the
position.
morning or in the evening?
Any time of the day, doctor, when I'm walking, I'm having these problems.
Okay. And you talk about you're feeling low energy. Is that
Yeah.
also throughout the day, or is there any variation in the morning time or in the evening time?
It is also associated with the exertion, doctor. If I'm doing the exertion, after the exertion, I feel I am tired, but it gets better after 5, 10 minutes.
Mhm. Have you ever heard any wheezing or whistling sound from your chest while you are taking breath?
No whistling sounds or noisy chest.
No, okay. And how is your waterworks? Is it the amount of the waterworks? Is it normal or it is going decreased?
Yeah, it is same as before, doctor. Waterwork is same amount.
And no frothiness or no change in the color of the waterworks as well, right?
No changes in the color and no frothiness. Yes.
Have you ever felt dizzy, blackout, have you ever fell down?
No, doctor.
Okay. And is there any, have you noticed any bleeding from any sides, like from your mouth or from your back passages?
No, doctor.
Okay. Do you have any past medical condition that should I aware of?
Yes, doctor. I'm known case of rheumatoid arthritis for 10 years now.
And what medications you are on?
Yes, I'm taking methotrexate and once in a week, and I'm taking folic acid also.
Mhm. And how is your rheumatoid arthritis? Is it under control?
Yeah, my disease is controlled, doctor. For last 5 years, I'm not having any problem. My disease is well controlled.
Okay. And do you have any raised body temperature?
I feel so likely my body temperature is increasing sometime.
Okay. And any change in the weight?
No significant change.
How is your appetite?
The appetite is bit low, doctor, in last 1 month period of time.
Mhm. And any joint pain or rashes now?
No joint pain and no rashes.
Okay. And you mentioned at times you have raised body temperature, right?
Yeah, yeah.
Uh, okay. And how is your bowel box?
Bowel works
How
are
is
regular, doctor, and
okay.
yeah, yes,
And
regular.
may I ask some personal questions?
Sure.
Do you smoke, Mrs. Julia?
No, doctor, I'm not smoking.
Okay. And do you take any alcohol?
Over the weekend, doctor, only 1 to 2 units.
Okay. And what is your job?
I'm a school teacher.
Okay. And is this condition how it is impacting your job?
Yeah, doctor. During giving the presentation or topic or teaching to the children, I feel I get the episode of shortness of breath and cough. So it is really affecting me.
Understand. Yeah, I completely understand. After examining you, after taking some more history, will definitely help you. Will come to the diagnosis and will definitely help you.
Thank you.
Do you drive, Mrs. Julia?
Yes, I do, doctor.
Mm-hmm. And have you ever had any blackouts or dizziness while driving?
No, doctor.
Okay. How is your periods?
My periods are regular, doctor.
Mhm. Shall I ask some personal questions as well?
Sure.
Do you take any birth pills to control your pregnancy?
Yes, doctor. Yeah, yeah. I'm taking OCPs.
Okay. And by any chance, are you pregnant now?
No, doctor. My doctor told me that you should avoid pregnancy.
Okay. Okay. Sir, I would like to do examination now.
Sure. So how you will start examination?
Sir, I would like to start with the hands to look for any deformities. I would like to keep
Okay.
the hand over the pillow, and I would like to.
No, no problem. I sent the picture in the WhatsApp group. Can you see there?
Sir, 1 minute. Yes, sir. Sir,
Okay.
I would
This is
like
the
to keep
hand.
the hand
Yes.
over the
Okay.
pillow and
Yes.
gently look for any nodules over the proximal interphalangeal joints, and look
Mhm.
for any swelling and palpate and I'll ask whether she is having any pain. If she is not having any pain, I'll just palpate the joints to look for any tenderness.
Okay.
And I would like to look for the functionality of the patient as well. I would like to ask the patient to close the hands and open it, and do prayer sign and reverse prayer sign balance test as well.
Okay.
Is that
What
normal, sir?
else? Yeah, it's normal, and you can see the hands. We will discuss this, and she has good functional capacity, and we will discuss this later on.
Okay, sir. And I would like to check for the pulse.
Okay, the pulse is 90 beats per minute, regular, good volume.
Okay. Then I move to the face to look for any pallor.
Yeah, she's slightly pale.
Okay. And any icterus?
No icterus.
I would like to move to the neck to palpate for any lymph nodes.
No lymph nodes, palpable.
I would like to move to the respiratory system examination. I would like to auscultate at the base of the lung to look for any how is the breathe sound, bilateral breathe sound? Is there any is it equal or any reduced breathe sound?
Yeah, yeah. You will go directly to the auscultation, or you will do something more on chest examination.
Sir, first I'll look for the inspection. Is there any decrease in the chest movements, and and I'll and then I'll go for the percussion to look for any dullness, and then I'll go for the auscultation to look for any reduced breathe sound or any crepitations at the particularly at the basal segment of the lungs, infrascapular area.
Okay, she is having bilateral inspiratory crepitations
Okay, sir. And
at the basis. At the basis.
yes, sir. I would also want to check the vertebra to look for any deformities.
Vertebra, no deformities.
Okay. I would like to auscultate for the heart to look for any murmurs or raise a palpable P2 or loud P2.
No.
And sir, I forgot. Is there a raise a JVP
No, JVP is not raised.
and any rheumatoid nodules over the elbow as well? Nothing. Okay.
No, no.
I would like to quickly check the abdomen to palpate for any splenomegaly.
Okay, not palpable. Okay, 2
And
minutes remaining.
I would like to just check for the pedal edema, sir.
Okay, no pedal edema, and 2 minutes remaining.
Mrs. Julia, what are your concerns to me?
Yes, doctor, what is wrong with me? Why I'm having difficulty in breathing?
So after taking a history and examining you, I have a few possibilities in my mind. The first thing is probably your lungs has some abnormality. It has gone into scarring formation. Because of this scarring, you are having all these symptoms that you are suffering from. And I'm suspecting the one of the possibility for this scarring in your case would be the tablet methotrexate that you are taking.
Is this the cause,
And,
doctor? This methotrexate is causing the scarring of my lungs.
the methotrexate, one of the bad effects of the methotrexate, it can cause the scarring of your lung when you are, especially when you are taking for the long term. And this we are keeping as one of the possibilities.
Okay.
And also
Okay,
the
doctor.
other.
So if it is the cause, then what you will do for me?
Yes. So we are planning to do some scans for your chest to look to confirm the diagnosis, what we are suspecting, to look for how severe the scarring is. So based on that, first we have to stop this methotrexate and will involve joint doctors to shift you to any other appropriate medications, alternative medications to control, to take care of your rheumatoid arthritis that you are suffering from. So after that, we will assess how severe the scarring of the lung. If it is an initial stage, we have alternative medications that will prevent the progression of the scarring. And if it is an
Okay.
depending upon the stage, we'll add some other medications as well.
Okay, thank you. Time is up. Now the examiner's question for 5 minutes.
Yes, sir.
Okay, Dr. Karthik. So summarize your case.
This is a 40 years old female presenting to us with the in-series onset progressive shortness of breath associated with a dry cough and malaise for the last 1 month. She is also a known case of rheumatoid arthritis, which is well controlled for the past 5 years on methotrexate therapy. On examination, I could find there is mild swelling in the proximal interphalangeal joint, and there is no deformity, and she is also having mild pallor, and she's having a bilateral fine crepitations, inspiratory fine crepitations.
Okay, so give me your differential diagnosis in this case.
First, as the patient
No, give me the differential diagnosis.
yes, interstitial lung disease, probably that might be methotrexate induced, or the possibility of the rheumatoid arthritis related interstitial lung disease, like UIP pattern of the interstitial lung disease. The uh, um,
Yes, at least two more differentials.
yes, sir. So the other possibility could be the interstitial. Sir, I don't know, sir.
No problem, no problem. It's okay. So any possibility of infections? He's having fever.
Yes, sir. The possibility of the infections like tuberculosis would be a possibility, as she is having a fever, or the um,
Good. Did you ask about the weight loss?
yes, sir. I asked for the weight changes. You have mentioned there is
Okay.
no weight change.
Okay, good. And shortness of breath could be because of anemia.
Yes, sir. Yes, sir. Shortness of could be anemia related shortness of
Why
breath.
she's having
Yes.
anemia?
Sir, I think it is the anemia of chronic disease because of the
Could
rheumatoid
be.
arthritis.
Yeah, you have to say could be because of anemia of chronic disease. Anemia
Yes.
of chronic disease. This is one of the possibilities. So here the
Yes.
differential diagnosis in this patient, you're right that it is the patient is having pneumonitis actually, pneumonitis, interstitial pneumonitis, methotrexate induced interstitial pneumonitis is the top of the differential diagnosis. The second possibility is interstitial lung disease as a part of rheumatoid arthritis pulmonary manifestation. This is the second possibility. The third possibility could be infections, and the fourth possibility, then the infection you can include at least 2 or 3 infections here. One is tuberculosis. The other infection, would you like to add anything else other than the tuberculosis?
Could be non-tuberculous mycobacterial infections or
Other than that,
histoplasmosis.
yeah, good. What else other than this?
Um,
Okay, no problem. We'll discuss this. Pneumocystis jirovecii can come also here. Okay,
yes, sir.
and
Yes, sir.
oh, okay. So then, okay, how you will investigate this patient?
First, I would like to confirm for confirming my diagnosis. I would like to do complete blood count to look for the hemoglobin, and the peripheral blood smear to look for any the morphology of the RBCs, and iron studies and vitamin B12 and folate level. I would
Good.
like to do a HRC, high resolution CT scan of the chest to look for any the changes of the pneumonitis or the interstitial lung disease. And as well as to look for any infection possibilities. Then I would like to do the pulmonary function test to look for any pattern of restrictive pattern of the lung disease.
Good.
And a 6-minute walk test to look for the functional ability, the baseline functional ability of the patient.
Very good. What else? Anything else?
Apart from this,
Good. How you will manage these patients?
If it is a methotrexate induced pneumonitis, I would like to stop the methotrexate and I can start the patient on alternative DMARD therapies like leflunomide or hydroxychloroquine. After I would like to explain the disease to the patient, and I would like to frame a multidisciplinary team involving the rheumatologist as well as the pulmonary rehabilitation services and the physiotherapist. And if it is a methotrexate-induced pneumonitis, I would like to stop the methotrexate and shift to the alternative DMARDs, leflunomide or hydroxychloroquine. And
that is done. Tell me something else.
Yes, sir. Then if it is a rheumatoid arthritis related ILD, if there is the GGOs NSAP pattern, I would like to start the patient on steroids. If it is and also on alternative steroid sparing agents like azathioprine or the mycophenolate mofetil. If it is then a UIP pattern fibrotic,
it's enough. It's enough. Thank you. What could be the complications?
The complications include the cor pulmonale and cor pulmonale leading to right heart failure.
Okay, good.
As, yes.
Okay, good. So there will be, I will give you the feedback about your performance in this case. Then we will proceed further. Okay, be with me. About your history, history was it's a bit slow. You are a bit slow in this. With this speed, you will not complete the things. Okay,
sir.
You are slow actually. So slightly you should be faster than this. Okay, Dr. Karthik.
Okay, sir.
There will be a lot of information in this case, so please be with us. And this is very informative case, dear colleagues. So when you start any system, you have to complete all the symptoms related to that system. So where are you? With the difficulty in breathing, the patient is having problem in the lungs or in the heart. Okay. Heart or the lungs. These are the two organs that can be involved in this case. Right or no?
Yes, sir.
So you have to ask, be with me. You have to ask all the questions related to the chest. Okay, the shortness of breath you started to ask, and completely you have to ask all the questions related to the shortness of breath. Okay, so you did this, and this was nice. How it is started and how it is progressing, any aggravating factor, relieving factors. Okay, and shortness of breath on lying flat, any paroxysmal nocturnal dyspnea is there or no? You asked about that. Okay, so these are all questions, very good. Together with this, then you have to ask the other symptoms. The other symptoms she is telling about the cough. So we have to ask about the cough is productive or dry. So she is having dry cough. Anything aggravating the cough, it is also important to ask. Anything relieving the cough, also important. But you ask these questions. Then the cough, if it is dry, then the question will be separate. And if it is productive, then you have to ask about the amount of the phlegm, color of the phlegm. Anytime did you produce any blood in the phlegm or no? So these are the type of the question for the phlegm production. And then what time of the day you are having the phlegm production. So but in this case, there is no productive cough. So we have dry cough. Other than this, in this system, you have to ask about the chest pain. Do you have any chest pain? Okay. Do you have any chest pain? Yes. If chest pain is there, you have to try to differentiate whether it is ischemic chest pain or non-ischemic chest pain. What type of the chest pain patient is having? Okay. So this was missing in your history. Chest pain, you did not ask. Okay, then
Yes.
shortness of breath questions also related. Did somebody told you that you are looking pale? It means you are asking the question of shortness of breath related to the anemia. Okay, this should be the first case, first question that you have to ask. Anybody told you are looking pale? This is the first question. Yes or no? If it is yes, then you will proceed from there and you will try to find out why the patient is having anemia. Okay, if the patient
Yes.
says yes, then you have to ask, do you take the balanced diet? Okay, then the second thing, then you will ask about, okay, do you have any tummy pain, any tummy discomfort? Do you have any black stools? This is the next other questions. Okay, the black stools, and then you have to ask about, did you pass any time blood from your back passage? Yes or no? So then do you pass, do you have any bleeding from any orifice? So you directly ask about bleeding from any orifice. It was not a good looking question, isn't it?
Yes, sir.
So you have to go systemically from low intensity question to higher intensity questions. Okay. Then if you did not found any clue for the anemia, then you have to go, because the patient is female, then you have to ask about, I would like to ask some personal question. What about your periods? Are they regular? Yes. Okay. What about the amount? Did you notice any excessive bleeding during your menstrual period or no? So these are the questions. So these are the questions are the complete package of the question you are asking about, and you are trying to find about the cause of anemia and the source of anemia. Clear?
Yes, sir. Sir, if the patient has told like no one has mentioned that I am going pale, then also
Yeah.
should we ask all these questions, or we can just stop?
If you think the anemia is prominent in your history till now, it is not prominent. So this much is enough. If you ask, do you take the balanced diet, and do you feel that if somebody is telling you are looking pale or no? If yes for the balanced diet and no for the other things, then no need further question, and you will come to this point after some time when you are asking the uh, uh, menstrual history of this patient. Okay.
Yes, sir. Okay, sir.
Then your case is related to the chest. Whenever we have a chest patient, we have to ask two system more. That is the joints, the rheumatological cases, and the kidney cases, and then the skin. These are three targets that we have to keep in our mind. Okay. Do you have any joint pain? And before going to this, I would like to say to all my colleagues that when you are taking the history, you started the history and the patient told you the presenting complaints. You have to stop here. Stop here and go directly and you inform the patient, please, I would like to know from you, do you have any long-standing disease that I should be aware of? Okay. So in the first 2 minutes, if you would have taken this history, that any past medical history is there or no, then you have to correlate. Might be in 20 to 30% of the cases, the patient will be having the problem related to the past medical history or the past surgical history and the medication history.
Yes, sir.
Okay, Dr. Karthik. So when you started and you asked about some question about the shortness of breath, cough and malaise, that's enough now. Go directly to the past medical history, okay, and the medication history, and try to correlate. If you have done this, then the job will be easy and you will become more targeted to this case, okay. The further question that were missing in your history, because you did not go to the past medical history early, then there was shortage of the time. So you did not ask about the follow-up. Okay. Are you in regular follow-up with the joint doctor? When was the last visit? Okay. And there is a routine testing for patient on lithotrexate. They have to do the CBC, LFTs, and the chest X-ray at the baseline, then at 3 months, and then every 6 months, or and according to the condition of the patient. Do you know this?
Yes, sir. I have
So
been
if you
asked.
if you have asked this question earlier, then you have to start making the correlation with the methotrexate and the symptoms. Okay. So how long she is taking? Say for 5 years. Any changes in the medication dose? No change in the medication dose. Are you in the regular follow-up? No, doctor, I'm not in regular follow-up. So you are just taking the medicine regularly every week. How many times you are taking in a week? This is another very important question. Doctor, I'm taking once in a week. So it is safe, but patient is not on regular follow-up. Do you take the folic acid tablet? Yes, I take. Sometime I forget. So if the patient is not taking folic acid, the chances of methotrexate toxicity is increasing. Okay. Now you are making the diagnosis of methotrexate induced pneumonitis. You have to ask about methotrexate induced hepatitis also. Do you have any tummy pain, especially the upper part of your right side of tummy? Do you feel feeling sickness? Do you feel any thrown up? Do you feel after eating the food it is difficult to digest, or you feel like heaviness in your tummy area or stomach area? So these are the questions that are very important to ask in this case. Okay.
Yes, sir.
This was the about the history. Then you did not ask about family history.
Yes, sir.
Okay. In the personal history, you are okay. The smoking is important, and the smoking can aggravate or it can increase the problem. If the patient is smoking, you have to inform the patient, highly recommend the patient that you have to stop smoking because you are developing the chest symptoms. Alcohol is very important. Again, if the patient on methotrexate, what is the normal range? What is the normal recommended dose or limit for alcohol intake in most of our patients,
14
most
units
of our
per
people?
week.
Huh?
14 units per week.
14 units. If the patient on methotrexate, how much he should take?
Hmm. I'm not aware of that.
He should avoid better. He should avoid. Okay. Why?
Yes. Might increases the liver toxicity.
Yeah, because we have to inform the patient whenever we are starting the methotrexate. In communication scenario, we have done one scenario before where we have to introduce the methotrexate. We have to inform the patient we are going to start methotrexate and what precautions we have to give. The important precaution is we have to inform the patient that methotrexate has to be cleared from the liver. Okay. And the alcohol has to be cleared also from the liver. So if you are taking both together, so the chances of having the toxicity or the side effects of this methotrexate will be higher. So it is highly recommended for you better to avoid the alcohol. If you cannot avoid, then the recommended limit for this patient is around seven units in a week. Okay. In that condition also, we have to explain the patient that we have to keep you under follow-up, and we will keep an eye. Better you should avoid. In this type of condition, we have to say the patient better you have to avoid. Okay.
Yes, sir.
Then your history, when you are taking the personal history, you are asking the patient any possibility of pregnancy right now. So it
Yes,
is
sir.
well known if the patient is on if on methotrexate, pregnancy is contraindicated.
Yes, sir.
Okay. So you can ask on other way. I believe that you are avoiding the pregnancy. Yeah. Or you are taking some birth controlling measures or the contraceptive measures. Okay. So she's on OCPs. But in whether the male patient or the female patient, both have to adopt contraceptive measures if they are on methotrexate. Okay. Then this is about the history. Then I will go to the examination. Your examination, you were focusing mainly on the hands of the patient at the start. But what you have to do in LCC, you have to focus where is the problem.
Okay, sir.
Okay. So where is the problem in this patient? The patient is having problem now in the chest, shortness of breath,
Respiratory.
cough. Yes. So hand examination, you have to do minimal in this patient. The chest examination, you have to do more. Okay. So hands I have shown in my WhatsApp group. So it was not having the active disease, isn't it?
Okay, sir. I thought like proximal interphalangeal joint is somewhat swollen. Okay.
Yeah, that are just like a bulky or a bogey swelling is there because of the long-standing disease. How long she is having the rheumatoid arthritis?
5 years.
No, she is taking methotrexate for 5 years, but she is diagnosed as a rheumatoid arthritis before this.
Okay.
Okay, take it 5 years. So if someone is having the rheumatoid arthritis for 5 years, so might be some changes occurring in the joints. That is normal. But in this case, in this patient, there is no redness, there is no warmness, there is no limitation of the movement of the hands and the fingers. Okay.
Yes.
That you ask, and I told you that, and you have to assess also. You
Yes.
can just do the hand grip, ask the patient to make a zero sign, or touch the index finger with the thumb and the little finger with the thumb, and try to detach them from both. Ask the patient to button up and unbutton up the shirt. You can ask the patient to hold the coin or the pen. So all these movements are possible in this patient. Then you have to ask if you're, then you have to go to the hand. You have to see the cyanosis is there or no. Okay, clubbing is there or no. Then you have to check the pulse. You have to check the saturation in this patient. SpO2 is very important in this patient. Respiratory rate is very important while you are doing the hand examination. While you are feeling the pulse, you should ask me how much is the respiratory rate of this patient, and I would like to check the saturation of this patient. Okay.
Yes, sir.
Then you go up and you will see the rheumatoid nodules are there or no. Then you will go to check the proximal myopathy is there or no. Then you go to the eyes. So slightly she is having pallor, otherwise no any deformities or no any further findings in the facial examination. Then you will go to the chest. You have to expose the chest in this patient completely, and you have to ask the patient to take a deep breath in and out. And after that, you have to ask the patient to cough for me. You want to know whether the cough is productive or the dry cough. Okay. Then you have to see any indrawing of the intercostal muscles. Is there any supraclavicular area, any depression is there or no? Is the patient is using accessory muscles or no? So in this patient, the respiratory rate was around 22 to 24. The saturation was 88% room air. Okay. And but the chest was moving equally on both sides. The palpation, the apex beat was okay on the fifth intercostal space, 2 centimeter lateral to the midclavicular line, and the trachea was central. Okay, and the chest expansion was equal and comparable on both sides. The percussion was resonant all over, especially except for the lower area where it was slightly dull. Now, on auscultation, there are fine inspiratory crackles. Then you have to see whether these crackles are changing with the cough or not.
Yes, sir.
Okay. That was also missing. So these are the positive findings in this patient, and this is the sequence of the examination. Then you will go and see the abdomen as you did, is splenomegaly is there or no. Then you will go directly to the feet of the patient and pedal edema is there or no. JVP is also one of the good thing to check. That's it. So the timing factor, and you have to see what is more important in this patient. And you have to modify your approach. Yeah. And mainly the focus, where is the problem? You have to go to that area as soon as possible. We have to start with the hand, no problem. But like in 30 seconds to 1 minute time, 30 seconds is maximum. In 30 seconds to maximum 1 minute, you should reach to the chest of this patient. Okay. And you have to spend at least 2 minutes on the chest examination of this patient. You have to see the scars also. Sometimes might be the patient previously having some pleurisy or pleural effusion, or the patient is having pneumothorax, some chest tube was done. So these are all things we have to find out. We have to try to find out these things. Okay. So coming back to the differential diagnosis. So in this case, the methotrexate interstitial pneumonitis. Still the patient is not developing the fibrosis, but interstitial pneumonitis is there with the low-grade fever. Patient is presenting, and the shortness of breath that is progressively increasing, and the dry cough mostly with the malaise. So this was the scenario actually in the exam. And the differential was the other manifestation of rheumatoid arthritis as a lung disease. So why it is unlikely that the rheumatoid-induced interstitial lung disease is less likely in this patient, but the methotrexate is more likely? Why it is like that? Why you chosen?
So there is active disease, and there is no deformities. There is no features of active disease.
Very good. This is the answer. This is the answer. We have to say the patient hands are not reddish. They are not warm. They are not having any deformities. Disease is under control. Patient is telling that my disease is under control. Symptomatically also, on examination also, you prove that the disease is under control. Where is the problem? The problem is with the disease control, if the patient is developing the symptoms, this is because of the medicine. Okay, so that is why you kept this for the top of the differential diagnosis, and this is the answer, how to give the answer. Other possibilities, other than the interstitial lung disease, the rheumatoid manifestation of pulmonary manifestation of rheumatoid arthritis. The third possibility is infection, and we have to rule out the tuberculosis and the pneumocystis jirovecii pneumonia. You have to ask the patient in the history. When the patient is telling you, I have the low-grade fever, what time of the day you are having the fever? Any sweating? What about your appetite is low or no? Okay, so these are the important questions. Then you have to ask, did you come in contact with a person who is having long-standing cough, or did you come in contact with a person who is having the infection known as tuberculosis? Okay.
Okay, sir.
So the examiner will take from you that this is a good candidate and he is asking the very specific questions. Okay, so this is the differential
Yes.
diagnosis. Now we will go to the investigation plan. So baseline investigation and specific investigation. Baseline, I will not go into the detail, but I will go directly to the specific investigation. Whenever you are talking about the investigation, Dr. Karthik, you have to start from low down investigation to upper level. Okay, don't go high resolution CT scan directly. In this patient, first you have to see the saturation. You would like to check the arterial blood gases if the patient is in respiratory distress, if the respiratory rate is 24 or above. So you will ask me about the saturation, you will ask about the arterial blood gases or the venous blood gases for this patient. Then you will tell me about the chest X-ray first. Okay, chest X-ray, then talk about the spirometry, then talk about the high resolution CT scan, then talk about the functional status. I will assess by the 6-minute walk test. So this will be the sequence of investigation. Then don't go directly to the high resolution CT scan. They don't like this. Okay. Then if the infection is, if they are focusing on infection, how you will diagnose the infection? So you will say that the patient is having dry cough. So in this case, we will go for bronchoalveolar lavage, the bronchoscopy and bronchoalveolar lavage to get the sputum sample or the secretion from the airways. Clear?
Yes, sir.
So this is the specific investigation for methotrexate interstitial pneumonitis. Okay, so on the basis of high resolution CT scan and the clinical findings, we will diagnose this, and you will make the multidisciplinary team in which the respiratory physician will be there, rheumatologist will be on board, and then the multidisciplinary team will also include the GP on board. Okay, and the occupational therapist and the physiotherapist will be on board, and the other specialty according to the symptoms of the patient. Okay, so then the non-pharmacological management and pharmacological management. In this patient, the non-pharmacological management will be, if he is a smoker, stop smoking. If taking a lot of alcohol, he should avoid it. And we have to give the oxygen to the patient. If the patient is hypoxic, room air saturation is less than 92%. In such condition, we have to give the oxygen, and we have to target saturation between 94 to 98%. If the saturation is low, you have to inform the patient that I will admit you, and we will run the test for you, and we will proceed from there. Okay, and then the smoking cessation plan, we have discussed. Dietitian we have to include, and then the further non-pharmacological will be included, like vaccination. Vaccination is very important. In all the respiratory cases, you have to inform the patient that vaccination is very important, and not only the influenza vaccine, but also pneumococcal vaccine and also the COVID vaccine. They want to listen now, the COVID vaccine. The patient, if the patient ask the patient, did you receive the COVID vaccine? Yes, so better to take the booster dose. Okay. Now the management of this patient. Management includes the certain principles in this patient. Methotrexate will be stopped here, and it will be permanently stopped. Okay, it will not be given again. This is number one thing. The second thing is we have to control the disease. Already the rheumatoid arthritis is controlled, but we have to give the medicine to keep it under control. So we have two possibilities now. Then we have to see the patient, what type of patient we are having. If the patient is having disease control, we can go to alternate DMARDs. Alternate DMARDs like leflunomide or sulfasalazine or hydroxychloroquine. Leflunomide will be the better choice, and hydroxychloroquine will be the next better choice. Okay, so what are the DMARDs medicine? DMARD medicine includes methotrexate, sulfasalazine, leflunomide, hydroxychloroquine, azathioprine. Okay, and then gold and penicillamine is the previous one we were using before. So these are the medicine known as DMARDs. So alternate DMARDs, we will go and we will monitor the patient under rheumatology care. If the disease remains controlled, well and good, we will continue. If the not under control, become uncontrolled now, then this is the time to move towards the biological agents. We will go for the biological agents. This is the complete package of treatment related to the rheumatoid arthritis. Then what about the pneumonitis the patient is having now? So we have to see the pneumonitis, we have to manage with the steroid. Okay, it is not the fibrosis, the patient is having the pneumonitis. So we will go directly to the steroid, and we have to start the steroid treatment, and we have to see the response of the steroid. Then the question will be how much it will be effective treatment option for the pneumonitis. So it is variable. Answer will be variable. It will be depending on the duration of development of the pneumonitis, number one. Number two, and the response of the treatment with the steroid. This is another answer. Okay. And if the patient is from pneumonitis is going to towards the fibrosis, then the chances of reversal of the pneumonitis will be lesser. Okay. So this will be the answer. So like this, we have to manage. So now the point is non-pharmacological management. And the pharmacological management, we have to divide mainly into two parts, the rheumatological disease and the lung disease. Now the patient is having the lung disease also. Then the complication they were asking you. So these patients at risk to develop the recurrent chest infections because the immunity is low. They are on a steroid or also this DMARDs also, and biological agents all will decrease the immunity of the patient. So they are at risk to develop the recurrent infections. The patient develop the pneumonitis, later on the patient is developing the fibrosis. The fibrosis will lead to type 1 respiratory failure first. And like this, type 1 respiratory failure, and then the cor pulmonale and pulmonary hypertension and cor pulmonale. So like this. Then the further complication related to fibrosis, patient at risk to develop the pneumothoraxis. Okay, these type of patient, they are at risk to develop the bronchiectasis also. So these are the possible complications in this case. Any question from the audience?
Sir, I have a question that you have said that methotrexate induced pneumonitis and how to differentiate from the interstitial lung disease. Like if there is no redness or swelling or deformity, then the disease is under control. So it will be like methotrexate induced pneumonitis in that case.
Yeah. Further, you will do the high resolution CT scan, and there is specific pattern for methotrexate in the high resolution CT scan.
Sir,
Okay.
Okay. In the methotrexate induced pneumonitis, the crackles will be fine, or it will be coarse.
It will be variable. It depends on the duration again and how much it is, and it is from fine to coarse. Okay. And once the patient is developing the fibrosis, then it will be the end inspiratory fine crackles, Velcro type, that will not be changing with the cough. In this patient, the crepitation is changing partially with the cough. Okay, this was not asked during the examination to me.
What's a specific treatment for pneumonitis in this situation? Can you just repeat it? And also, for how long did this patient have these symptoms? I missed that, I think.
Yeah, it was 1 month duration only. It started 1 month ago.
Okay, and can you just is it just steroids that we give for pneumonitis, right?
Yeah, steroid is the mainstay.
Okay, that's fine. Thank you.
Sir, how long we have to give steroids? Is there any steroid sparing agent do we need to add for methotrexate induced pneumonitis?
I'm sorry, my internet was disconnected partially. Okay, so mainstay of treatment is a steroid for interstitial pneumonitis related to methotrexate.
Sir, how long we have to give steroids?
Yeah, it will be again depending on the severity of the illness, and mostly it will be like 4 to 6 weeks period of time.
Okay, sir. And do we need to add any steroid sparing agent?
Yeah, we have to give the we have to give the stomach protection, we have to give calcium, and we have to give the vitamin D also. Bone protection, the stomach protection are mandatory. Whenever you are giving any patient more than 2 weeks course of steroid, we have to give. Also, stomach protection, you have to give whatever the duration you are giving a steroid. Okay. The bone protection you have to give if the patient is on more than 2 weeks treatment of steroid.
No, sir. Is there any alternative agent do we need to start to as a
Not now.
steroid sparing agent, like
Not
azathioprine?
now. Not
Can I
now.
talk?
Not now.
Okay, sir. Thank you, sir.
Just
Can I talk?
so, yeah, 1 minute, please.
Can I
I want to
talk?
explain. Yeah, please go ahead. Yes.
My name is Dr. Jan from Alexandria, Egypt.
Welcome, doctor.
I suspect that this patient has no interstitial fibrosis. There is no media to cause him interstitial fibrosis, and he has no cyanosis. So the interstitial fibrosis is not diagnosed.
No, we did not tell about the fibrosis, doctor. We told interstitial pneumonitis.
Okay.
The patient not develop fibrosis. We are not seeing any clubbing in this patient. We did not found any cyanosis in this patient. There is hypoxia. Yeah, there is hypoxia in this patient, and the candidate did not ask me about the saturation. The patient is having interstitial pneumonitis. This is the new thing the patient is developing. Still the fibrosis not developed.
Okay.
Okay. So it is not interstitial lung disease, or it is still the patient is not developed the fibrosis, but the patient is having pneumonitis right now. Thank you, Dr. Jihan.
And the patient also not working in media, causing interstitial fibrosis.
Sorry?
The patient also not working in a media causing interstitial fibrosis.
Your voice is not clear.
Like industry, silicon industry.
Yes.
Like silicon industry, the patient is not working in silicon industry, for example.
Yeah, that is the interstitial causes
For
of
example?
fibrosis for interstitial lung disease is still there. But the candidate asked about the exposure, and the patient told that the patient is working as a school teacher. She is not working in any industry.
Okay.
So you are trying to rule out the other causes of interstitial lung disease in this patient. So in this patient, we have to rule out, yes, you are right, on the history, what is the job of the patient, any occupation, any, is she living near to the industrial area? This is also one of the factors. Then the drug-induced causes is also there, interstitial lung disease. There are many causes for interstitial lung disease.
Also, I searched for tuberculosis. The patient may have tuberculosis.
Yeah, we put this in our differential diagnosis.
The patient may have.
Yes. We put here 4 or 5 differential diagnosis, doctor, and the tuberculosis is included in that. Okay. Thank you so much.
Okay.
Any other question? You are welcome. Okay, the previous someone was asking about the steroid sparing agent. So we will not start the steroid sparing agent from the start. We have to start with the steroid, and like 1 milligram per kg we will start, and we will continue for 2 weeks, and then we will see the symptoms are improving, condition is improving. Yes, then we will reduce the dose. Okay. Once we are reducing the dose, symptoms are increasing, it means we have to go for steroid sparing agents also. At that time, the mycophenolate mofetil is a better choice than the azathioprine. Okay, mycophenolate mofetil will be the better choice. And then we have to see what pattern the high resolution CT scan is showing to us. If it is ground glass more, then the steroid will be giving us more response. If it is not the ground glass opacity on the high resolution CT scan, if the fibrosis is predominant, then we have to go for antifibrotic agent, then this steroid. Okay, so high resolution CT scan also will guide us. So now what we are discussing like the possible findings in this patient. The possible finding in this patient is like pneumonitis because of the methotrexate. The mainstay of treatment for methotrexate interstitial pneumonitis is the steroid. The duration of steroid again will be decided by the multidisciplinary team, but generally at least for 4 to 6 weeks, and we have to see the response. If it is slow response, then we have to extend the duration, maybe 8 weeks or 12 weeks, or maybe we will add the steroid sparing agents. And when we are reducing the dose of steroid, the symptoms are increasing, condition is worsening. In that condition also, we will go for steroid sparing agent. I hope it's clear now.
Yes, sir. Thank you, sir.
Yes.
Thank you very much for joining us today. I think my contact number is clear to you people. It is from Saudi Arabia, 00966. And so you can put like +96 00966, yeah, 96659
Egypt.
3737 900. Okay, anyone who wants to join, send me message. I will send you send me a message on WhatsApp, please. Okay, so I will
How
send
many
you.
contacts from Egypt?
Sorry,
How many contacts from Egypt? How
from
many
Egypt.
doctors from Egypt?
I think you are the one only till now, but I have the many candidates from Saudi Arabia and Middle East. They are in our group.
Okay.
What you are working, Dr. Jihan? Dr. Jihan, you are
What
working
do
in
you call?
Egypt?
I am consultant cardiologist.
Okay, welcome, Dr. Jihan.
I am
Welcome.
consultant cardiologist.
Welcome. Happy to know about you. I'm consultant pulmonologist, and quite a few, many colleagues of mine, they are working here in Saudi Arabia with us. They are from Egypt. Okay. Thank you.
I have
Thank you very much.
doctorate in cardiology.
Very good, doctor.
Thank you.
Thank you so much. Okay, so we will end this meeting now. And thank you very much for joining today.